Everyone. I'm Dr. Sandra McDonald, and I'll be your host and facilitator for this afternoon. I'm the Quality and Wellness Manager here at the Authority, and we'll be discussing this afternoon men's health issues. Joining me on the call this afternoon is my colleague, Mrs. Chandra Sawyer. She is a health and wellness specialist here at the Authority. So on behalf of the board of directors, the team at NHI and the hardworking folks who share this platform with me, as well as work at the Authority, we want to welcome you to our educational session this afternoon. The focus of this afternoon session is to discuss men's health. And it is my esteemed privilege to introduce to you and to share with you that Dr. Bert Williams, who is one of my colleagues and friends working out of Frederick, Maryland, he will be talking to you about men's health issue and joining us later on in the program. As always, the session is designed with you, the Bahamian public, in mind, and the goal of this afternoon session is to introduce you to the importance of men's health and the importance of men taking care of themselves and encouraging men to make education as well as self-care priority. But before Dr. Williams come, I want to talk to you a little bit about NHI, who we are, our mission and our vision, and finally where we are and where we are going in from an organizational perspective. Our vision here at the Authority is to lead the way in providing affordable and equitable care to all Bahamians. Our mission is to transform the current healthcare system, understanding that the future well-being of Bahamians depend on the health of our nation, because we understand that the health of our nation determines the wealth of our nation. We want to ensure that patients are at the center of the care that we're providing and that they are a part of the decision-making process here at NHI, as well as you who are a part of our network of providers, and making sure that you're engaging our patients in the decisions that you're making about their care and allowing them to participate in the care that they're receiving from you as providers. So how do we demonstrate what we're trying to accomplish from a mission and a vision perspective? We want to make sure that we're providing passionate care and that we're focusing on universal health care for all Bahamians. We want to make sure that we're progressive about expanding access to quality care by providing innovative and supportive solution by introducing the latest technology. We want to make sure that we're creating partnerships with our providers and making sure that we're delivering quality care and that the care that we're providing is being offered through making sure that it's, from a business perspective, the care is being offered with integrity, honesty, and accountability, and that it's transparent in a transparent format, as well as demonstrating that we're committed to the success of our beneficiaries and being sincere about the care that we're providing. And finally, we want to make sure that the care that we're providing is being offered in a respectful manner, and that our beneficiaries are at the center of the care that we're focusing on. As a part of NHI Health and Wellness Program, we're committed to creating platforms to educate, inform, and encourage Bahamians to adopt and embrace healthy lifestyles by understanding how lifestyles impact health outcomes, and the importance of eating healthy, because we recognize that food is as medicine, and that you're engaging in a balanced diet, and that it's important that you integrate exercise into your daily routine. We want to make sure that you're focusing on self-care and that you're taking care of yourself emotionally and mentally, and that you understand the importance of eliminating stress from your lifestyles. So where we are now, over the last 5 years, we've been focusing on impacting care in the Bahamas and making sure that we are leading the way in terms of providing quality care in country and transforming the way we do business here in country. As you probably are aware, there's been a heavy burden on the hospital system. So the goal of this of NHI is to eliminate the burden on our tertiary healthcare system like the hospital, and then place the emphasis back on primary care and preventative healthcare. How do we do that? By making sure that the technology that we have is user-friendly, not only for you as beneficiaries, but also for our providers by using the electronic health record system and ensuring that we're engaging in telehealth. We want to make sure that the authority continues to offer primary health care. Currently, we have about 130,000 Bahamians enrolled in the program, and our goal is to continue to enroll other Bahamians into the program. We want to make sure that the care is not only accessible to individuals here in Nassau, but it's being offered around the family of islands. Currently, we have 17 islands engaged in the program, and that includes islands like Exuma, Grand Bahama. We're also in Abaco. We're also in Bimini. So we have about 17 islands engaged in the program, and our goal is to ultimately expand the program around the length and breadth of every island in the Bahamas. We have about 5,700 children enrolled in the program currently, and about 14,000 seniors, and we'll continue to expand the program in the months and years to come. We currently have about 104 physicians enrolled in the program at 57 primary care facilities and 16 labs, and our goal is to expand that process going forward. As we focus on national health care, we've been engaging our providers and making, as well as our beneficiaries, and about 95% of our patients tell us that they're extremely satisfied with the program. They're extremely satisfied with the services that they're receiving from our panel of our network of providers. And our goal is to continue to expand that and continue to work on the quality aspect of the program. We want to make sure that we continue to expand the program around the Bahamas to make sure that no Bahamians are left behind, that everyone have access to quality care in every island, as well as not only in New Providence. So as we focus on growing the program, making sure that the technology is cutting edge and it's what it needs to be, so that it's not only user-friendly for our beneficiaries, but as well as our network of providers. So with that being said, I'm going to now turn the program over to my colleague, Chandra Sawyer, who's going to introduce Dr. Williams, and then we'll move forward with the program. I encourage all of you, if you have questions around anything we discussed this afternoon, to please put them in the chat, and we'll get to your questions at the end of the presentation. Thank you again for joining us this afternoon, and we look forward to a vibrant conversation.
Good afternoon, everyone. The term men's health is used to refer to the physical and mental health problems that are of concern for men. The differences in men's health compared to women's health can be attributed to 1, biological factors, genitalia or hormones. 2, behavioral factors. Men are more likely to make unhealthy or risky choices and less likely to seek medical care. And social factors. Example, occupational lifestyle differences. The role of men in the family is to be the priest, provider, and protector. However, if they are plagued by chronic diseases such as diabetes, hypertension, heart disease, and prostate cancer, this impedes their role to be effective in their families and in the community. The culture of Bahamian men creates a wall around their health that is often hard to break down. Men are reluctant to get medical care and ignore the signs and symptoms which their bodies experience. Under the NHI Bahamas program, the primary care benefits offered specifically for men include general physician visits, annual physicals, laboratory testing, cancer screenings, the prostate-specific antigen test, also known as the PSA test, vaccines or immunizations, HIV/AIDS and STD screening, and chronic disease management. According to the world data in 2020 in the Bahamas, the general life expectancy, which is the theoretical age that a newborn child could potentially reach today, is 71.8 years for men and 76.2 years for women. Thankfully, most men's health threats are largely preventable, providing opportunities for awareness and education among Bahamian men to sensitize them on health conditions which can be prevented through early detection and screening is important, and it will help to reduce premature death among the men. This is the purpose of tonight's session. This evening, we want to take the time to introduce Dr. Bert Williams, who is a board-certified urologist who has practiced for over 2 decades in Frederick, Maryland. He is the CEO and founder of Mid-Maryland Urologic Services, with offices in Frederick and Gettysburg, Pennsylvania. Dr. Williams also serves as a consultant in the Bahamas and has served as the chairman of the urology department at Frederick Memorial Hospital. He is a diplomat of the American Board of Urology and the National Board of Medical Examiners. He is licensed to practice medicine and surgery in Maryland, Pennsylvania, and the Bahamas. He is a graduate of the Government High School in Nassau, Bahamas, the Britannia Royal Naval College in Dartmouth, England, Howard University, and the Howard University College of Medicine in Washington, D.C. He completed his training in general surgery and urology at Howard University Hospital, and to date, Dr. Williams has thriving practices. He has received numerous honors and awards throughout his education and career. Some of these include the American College of Surgeons, the Washington Metropolitan Who's Who Among Physicians, and the Consumers Research of America Top Urologists. He is a member of multiple national honor societies. Dr. Williams is also a member of the National Medical Association, the American Urological Association, the Mid-Atlantic section of the American Urologic Association, the American Association of Clinical Urologists, the American College of Surgeons, the Washington Urologic Society, the Maryland Urologic Society, the Frank Johns Urologic Society, the Bahamas Medical Council, Pennsylvania Medical Society, and he is a founding member of the Ulysses Bourne Vanguard Medical Society located in Frederick, Maryland. Dr. Williams has presented on numerous occasions nationally and internationally on subjects related to his specialty and has an interest in men's health issues, female incontinence, and pelvic floor issues. More importantly, he is a native son of the Bahamas and is married with a teenage daughter. He is also the dad to a Yorkie Poo latte. He's an avid runner, a scuba diver, and a frustrated artist. This evening, I would like to take this time to welcome to all of you that are on the call, Dr. Bert Williams.
Thank you for that elaborate introduction, Chandra. But without further ado, we'll get into the presentation. And today, I will try to bring about men's awareness to some of the more common problems we see in men, how we address prevention of those problems, and hopefully educate my audience as well as myself through the questioning that come about at the end of the program. Next slide, please. So some of the more common problems we see in men are metabolic syndrome, erectile dysfunction, benign prostatic hypertrophy, prostatitis, both acute and chronic, and prostate cancer. I will attempt to summarize these problems and show how they interface and how primarily metabolic syndrome affects everything. Next slide, please. So metabolic syndrome is a combination of obesity or a body mass index of greater than 30, and a waistline of greater than 40 inches in men or greater than 35 inches in females. You can also see elevated triglycerides or cholesterol, a low high-density lipoprotein. The high-density lipoprotein is the good cholesterol, which protects against heart attacks. And if it's less than 40, there are concerns related to the possibility of cardiac problems when we see this. High blood pressure is another one of the problems associated with metabolic syndrome, and elevated blood sugar or diabetes. Next slide, please. So why metabolic syndrome? It matters in everything, as I said earlier. There's an increased trend worldwide in metabolic syndrome. In addition, it increases the risk of myocardial infarction or heart attacks, stroke, liver disease, kidney disease, sleep apnea, sexual dysfunction, and cancers of all kinds. As we have seen recently in the COVID epidemic, it increases the complications and death rate of patients infected with COVID. Next slide, please. So how do we treat it? The biggest treatment is prevention, and that would include increasing exercise, at least 20 minutes daily or 3 times weekly, weight loss, portion control, and change in your lifestyle. For example, not eating after a certain hour or cutting back sugar and alcohol intake. There's also requirement of increased water intake and mindfulness and spirituality. Let's stop for a minute on mindfulness and spirituality. Mindfulness is essentially taking time out to, as I would call it, get in a quiet place, reflect, and involve oneself in introspection. This allows us to look at ourselves critically and where we are from not only a health standpoint, but a socioeconomic standpoint, as well as a psychosocial standpoint. And spirituality speaks for itself. We have to be connected to something greater than ourselves as we go through this sojourn called life. Next slide, please. So this is just an illustration of the genitourinary system. And as you can see, the kidneys are at the top of the picture, and those structures that come from the kidney down into the urinary bladder are called the ureters. Unfortunately, I don't have a pointer. I would be able to point those out. Next slide, please. This is a cross-section of the male genitourinary system. And as you can see, the urinary bladder is at the top of the picture, and the prostate sits just beneath it and along the anterior wall of the rectum. The urinary tract courses through the prostate and ultimately through the penis and out of the body. The anatomy of the prostate allows better examination via the rectum, hence the necessity and the importance of the digital rectal examination. Next slide, please. So we'll skip on to talk about erectile dysfunction. And erectile dysfunction is essentially the inability to obtain or maintain an erection adequate for sexual function or penetration. It usually indicates another health problem or related factor. There's an old adage that we use in urology, and it goes as such. If you cannot look down and see your pee-pee, the problem is your belly. Next slide, please. The primary cause, or the most common cause of erectile dysfunction, particularly in the United States, is smoking. And this happens because smoking causes damage to the small blood vessels that feed the nerves responsible for erection, as well as the sinusoids in the erectile tissue in the penis, resulting in decreased blood flow to the penis and hence a subpar erection. Diabetic neuropathy acts essentially in the same way by damage to the penile nerve and hence a subpar erection. Neurologic diseases such as Parkinson's disease, multiple sclerosis, and stroke act in the same way that diabetes does. And just to digress a little bit, the autonomic system, which starts deep in the brain, is responsible for the whole neurosexual response. In other words, you see, you feel, you touch, taste, etc. And then that gets transmitted to neurohormonal releases that result in erection, the process of excitement and orgasm, and ultimately resolution of the sexual cycle. This whole process is affected by damage to that autonomic nervous system, which is seen in diabetes, smoking, and any disease that affects the neurologic system. Obesity and hence metabolic syndrome is a major factor because obesity and metabolic syndrome create all of these other problems such as diabetes, hypertension, hypercholesterolemia, which creates a vicious cycle and result in subpar sexual activity and the sexual event. Next slide, please. Again, atherosclerosis decreases blood flow to the nerves and the tissue in the penis, and again, causes an inadequate erection. The medications used to treat hypertension result in decreased blood flow to the penis, since these medications relax smooth muscles in the blood vessels in other parts of the body. As a result, the blood flows in the direction of least resistance, leaving a suboptimal amount of blood to be transmitted into the erectile tissue in the penis, and hence a subpar erection. There are psychiatric conditions and medications that also affect the erectile function. Depression, for example, releases stress hormones. Anxiety releases the hormones that are responsible for resolution or ending of the orgasmic phase, such as norepinephrine and epinephrine, and hence block your ability to get an erection. Peyronie's disease, I'm sure some of you have seen pictures of the bent carrot on TV, and this is as a result of Peyronie's disease. Peyronie's disease is named after the personal physician of Louis XIV, whose name was Francois de la Peyronie, and he actually discovered this disease. And it's due to trauma. Sex in and of itself, or the act of sex, is traumatic. And if the penis is bent in an awkward way, there's damage to the blood vessels that are responsible for transmitting blood to the erectile tissue, and that damage heals as a scar. And that scarring occurs in the erectile tissue and causes the penis to curve in the direction of that scar. This can also cause a decreased caliber of your erection, as well as an inability to obtain an erection. Peyronie's disease, by the way, is treated with injections of a collagenase to the scar in the penis. Next slide. So, erectile dysfunction can also be caused by treatment of other problems in the genitourinary system. For example, some of the treatment modalities we use for benign prostatic hypertrophy. Medications used in benign prostatic hypertrophy, such as 5-alpha reductase inhibitors that help to shrink the prostate, also cause a decrease in your libido. And this results in lowered sex drive and ultimately a problem with getting an erection. Surgical procedures used to treat benign prostatic hypertrophy, such as transurethral resection of the prostate, laser treatment of benign prostatic hypertrophy, and any heat modality can damage the nerves that are responsible for your erection and course along the lateral aspects of the prostate. These nerves are damaged by the effect of the heat on blood vessels that feed them, resulting in death of the nerves and ultimately a lack of an erection. Cancer treatments can also cause problems with erection. For example, some of the treatment modalities we use for prostate cancer, radiation therapy and surgical removal of the prostate, again, cause damage to the nerves that are responsible for your erection and ultimately a loss of the ability to obtain and maintain an erection. The chemotherapeutic agents affect your production of testosterone and hence decrease your libido and ultimately affect your erection. Next slide, please. So how do we diagnose erectile dysfunction? You first have to start with a history and physical examination. We want to find out what exposure the individual has had, whether it was surgical or lifestyle exposure, alcohol intake, tobacco use, and the patient's general lifestyle activity, whether they are sedentary, what are their dietary habits. And then we move on to do a physical examination. And that physical examination involves a whole body examination from head to toe. The digital rectal examination is a part of that. It receives a lot of controversy, but it is required in order for us to evaluate whether or not your erectile dysfunction may be due to something else going on with your prostate. Following the history and physical examination, we proceed to obtain labs, and we look at your comprehensive metabolic panel, where we evaluate your kidney function, your liver function, and the electrolytes in your blood. All of these things tell us information that would allow us to diagnose and treat you better as it relates to your erectile dysfunction. The complete blood count also tells us about infections, whether or not you're anemic, and that kind of stuff that would allow us to treat you better. Testosterone level is essential because testosterone is the fountain of youth for men. And if it's low, that has to be addressed. Not only is testosterone responsible in your libido and sex drive, but is also responsible for muscle and bone development in men. So these are other things that we have to address in order to improve your sense of well-being. And the PSA is definitely important because we need to know whether or not your erectile dysfunction is as a result of prostate cancer. If your PSA is elevated, then that would require additional in-depth evaluation. The lipid panel helps us to determine whether or not you have hypercholesterolemia, which can result in blockage of your blood vessels and affect your erection. Not only is it important in the erection, it can also determine whether or not we need you to be evaluated by a cardiologist so that we know that we're doing the right and appropriate treatment and that you don't have some other issues that may be of dire consequences. We also do a sexual history evaluation score and refer patients for cardiology evaluation, since erectile dysfunction may be the sentinel event that lets us know that you may have coronary artery disease and be at risk for a heart attack. Next slide, please. So we treat erectile dysfunction first by including the spouse. I think this is the most important thing we can do when we treat erectile dysfunction. The significant other should always be included in the discussion, simply because we need to know whether or not that individual is aware of what's going on with their partner. Also, we need to know whether or not that individual is interested in sexual activity, because that can also be a problem. We have to treat both arms of the partnership. Then we have to talk about behavioral activities, exercise, weight loss, diet, and giving up on or decreasing significantly alcohol intake, as well as cessation of tobacco use. Now, we have a multitude of medications that we give for erectile dysfunction, and I'm sure most of you know Viagra, Cialis, other drugs like Levitra. We have Staxin and Stendra. There are a whole litany of them, but they don't all work for everyone. So we have to find out what your underlying problem is before we can initiate medical treatment. Testosterone replacement therapy may also need to be evaluated. And in some cases, we give penile injections, particularly in patients who may not tolerate oral medication or are not candidates for the oral medications. And we have another medication called urethral suppositories. These are not used as frequently, but they have the same effect of a penile injection. And last but not least, we utilize penile prosthesis. This is the most invasive way to treat erectile dysfunction, and it is the last resort. Next slide, please. Next slide, please. So I'll talk a little bit about prostatitis, since this is a disease that is not mentioned a lot when we are talking men's health, but it's the inflammation of the prostate gland, and it can be caused by bacteria, or it can be non-bacterial. It comes in an acute and chronic form. The acute form is associated, next slide, please. The acute form is associated with fever and chills or flu-like symptoms. Essentially, patients have lower back, lower abdominal pain, perhaps painful urination, painful defecation, and painful ejaculation. At times, patients may have incomplete bladder emptying and a very slow urinary stream, and there may be blood in the urine. Any combination of these symptoms will constitute prostatitis. Now, chronic prostatitis is the same without the fever and chills or flu-like symptoms. Next slide, please. So the risk factors for acute prostatitis are urinary tract infection, sexually transmitted diseases, unprotected sex, and medical procedures, such as what we just talked about. Endoscopy for benign prostatic hypertrophy, catheterization, treatment for kidney stones, all of those can lead to acute prostatitis. And it's a lot of times seen after we have done a procedure, particularly the prostate biopsy. It can also be seen in patients who habitually hold their urine. For example, if you're on a long trip or you're on an airplane and you don't want to get up to go to the bathroom, sometimes when you actually get to go to the bathroom, it's difficult to initiate your urinary stream. And that's why we do not suggest habitual holding of your urine. Next slide, please. So as we said earlier, the symptoms of chronic bacterial prostatitis are the same as those seen in acute prostatitis without the flu-like symptoms. Next slide. Again, the factors associated with chronic prostatitis are the same as acute. Continue. Next slide, please. And the treatment of prostatitis is multimodal. We can use medication or a combination of medication, dietary restrictions, behavior modification, and lifestyle changes. Next slide, please. So some of the medications we use include antibiotics, definitely in acute prostatitis and chronic bacterial prostatitis, we'll use medications. In the case of the acute phase, IV antibiotics are sometimes necessary. And with chronic prostatitis, long-term antibiotics is necessary. So sometimes we have to treat up to 4 weeks with antibiotics to effectively treat chronic prostatitis. We also use some of the medications for benign prostatic hypertrophy, which help to relax the smooth muscles along the urethra and allow appropriate urination, since this problem swells the prostate and can cause urinary obstruction. Again, ibuprofen and naproxen are used to help with decreasing the inflammation and improve urination. Antidepressants are used sometimes in the event a patient is having becoming depressed because they are having these symptoms. It can be very chronic and debilitating, and so low-dose antidepressants are used to improve patients' sense of well-being. And medications such as pregabalin are used in the case where the prostatitis symptoms are due to radiculopathy or neurologic problems. In other words, some patients have these same symptoms but have lower back problems such as herniated discs, and the manifestation of the herniated disc can mimic chronic prostatitis. And in using pregabalin and amitriptyline, as well as Elmiron, we help to significantly decrease the symptomatology of the radiculopathy, and in so doing, improve urination. Antioxidants are also helpful, and it is recommended under normal circumstances that men take antioxidants. For example, we use multivitamins for men age 50 plus, and even men under 50 that have zinc, selenium, lycopenes, and saw palmetto, all of which are antioxidants and help to improve inflammation and prostate health. Next slide, please. There are also non-drug therapies for prostatitis. In the case of radiculopathy, we can use implantable neuromodulators, trigger point injections where there are herniated discs. Acupuncture is also used. Pelvic floor physical therapy. This helps to relax the pelvic floor because prostatitis can cause spasms of the pelvic floor and the perianal muscles. And pelvic floor physical therapy is paramount in these cases. Biofeedback is helpful in allowing patients to focus on the source of their pain and help to improve it through meditation and relaxation techniques. Transcutaneous electrical nerve stimulation helps in the case of radiculopathy or nerve injury. And the newest kid on the block is shockwave lithotripsy or extracorporeal shockwave lithotripsy. And this works by sending sound waves into the affected area and to stimulate healing at the treatment site. This is new and still in the developmental phase. Next slide, please. I'll talk about this just briefly because we see more patients with the symptoms of chronic prostatitis who have no bacteria in their urine, And we have to treat expectantly. In other words, we do all the non-medical treatment for prostatitis in these patients. But greater than 90% of patients with prostatitis have no obvious bacteria in their urine, and therefore what we call expectant management or conservative management is used. So diet in these patients is essential. Avoiding spicy foods, alcoholic beverages, very acidic foods and beverages, because these all irritate the prostate as well as the bladder, since they are avoided out in the urine or expelled from the bladder, from the body through the urine. Next slide, please. Next slide. So I'll go on to talk a little bit about benign prostatic hypertrophy, and then we'll get on to talk a little bit about prostate cancer. So benign prostatic hypertrophy is benign growth of the prostate. And it's due to the fact that we all men produce testosterone throughout their life, and testosterone stimulates prostate cells to grow. This process begins at puberty, when we start to grow a beard, our Adam's apples enlarge, and our voices deepen. That is when we get our first testosterone surge, and that is when we get our first prostate growth surge. There seems to be an associated risk with a high-fat, low-fiber diet and low vitamin D levels. So we encourage men to take vitamin D and to pursue a high-fiber, low-fat diet for good prostate health. This problem has a significant impact on lifestyle and urinary tract health. Next slide, please. Some of the symptoms of benign prostatic hypertrophy: frequent urination, urinating frequently at night, more than 2 times at night, hesitant urination, intermittent urination. In other words, you urinate and it stops midstream and then starts back up again. Urinary tract infections are a sign of benign prostatic hypertrophy, since urinary tract infections are not common in men. And when we see it, that gives us a hint that something else might be going on. Urgency of urination is another problem. Incomplete bladder emptying, and last but not least, blood in the urine or hematuria. Next slide, please. So we diagnose benign prostatic hypertrophy much in the same way we do everything else: a history and physical examination. We ask patients to fill out what we call an American Urologic Association symptom score, and that score is out of 35. If your score is under 7, then that's the normal range. Between 7 and 18 is moderate, and 18 and above are severe symptoms. We also get labs which will include the basic urinalysis to rule out urinary tract infection or other issues that might be going on. And then the PSA is paramount. We also do a test called a urine flow test, where we have the patient come in with a full bladder and they urinate into a specialized machine. And this gives us an idea of their flow rate. The average flow rate should be above 10 cc's per second. If your flow rate is under 10 cc's per second, then we have concerns. We also do an ultrasound of the kidney and bladder. This allows us to see whether or not there's incomplete bladder emptying and collateral damage to the kidneys. Hydronephrosis and hydroureter, which is dilation of your passages that bring urine from your kidney into the bladder, and dilation of the kidneys themselves, indicate obstruction, even though the patient may be asymptomatic. The ultrasound allows us to see this and to act accordingly. Cystoscopy is the final rung of the diagnostic process. And we are basically looking into the bladder to see how much the prostate is obstructing the bladder neck. And if in fact it's only the prostate that's obstructing the bladder neck, because scar tissue along the urethra can act in the same way as an obstructing prostate. Next slide, please. We treat benign prostatic hypertrophy with medication or non-invasive means, and then surgery or invasive means. Next slide. So drug therapy or non-invasive therapy include what we call alpha blockers, and there are a litany of them again: Flomax, Uroxetrol, Rapaflo, Cardura, to name a few. And these act by relaxing the smooth muscles along the urethra as it courses through the prostate. This allows easier urination and emptying of the urinary bladder. We also use anticholinergic medications to relax the smooth muscles in the bladder itself. Once the prostate starts to grow, it changes the dynamics of the muscles that line the wall of the urinary bladder, and they become hyperactive because they have to work harder in order to expel urine from the bladder. So in order to mitigate those symptoms, we give low doses of anticholinergic medications, which relax those muscles and allow us to empty our bladder appropriately without having to run to and from the bathroom frequently. The newer form of drugs for the smooth muscles of the bladder are called beta-3 agonists. And you may know them as Mirabegron or Vibegron. These act differently than anticholinergic medications in that the side effect profile is much better. Anticholinergic medications can cause dry mouth, constipation, and blurred vision. The beta-3 agonists do not have that effect, but they can cause hypertension at the higher doses. So that has to be observed for. Tadalafil or Cialis is also used in treating benign prostatic hypertrophy because it has the same effect of relaxing smooth muscles along the urinary tract. And 5-alpha reductase we talked about a little bit earlier. These medications act by stopping the conversion of testosterone to its active form. The active form of testosterone is called dihydrotestosterone. And so 5-alpha reductase inhibits the conversion of testosterone to dihydrotestosterone. That dihydrotestosterone stimulates prostate cells to grow, whether they are benign or malignant. So this medication helps to prevent that. However, it has a downside of affecting the libido negatively. Next slide, please. Some of the non-invasive therapy and drugs that we use outside of prescription drugs would include vitamin D3, saw palmetto, which is a medication, a natural medication from a plant grown in the southern parts of the United States, primarily the Carolinas. Saw palmetto is an anti-inflammatory type medication, and it helps in the process of emptying, as well as any discomfort experienced in the prostate during prostatitis. Beta prostate is seen a lot on television, and it has some of the same products in it, like multivitamins, such as zinc, lycopenes, and selenium. Another biggie is lifestyle change and dietary change. You will see this all along. Metabolic syndrome again. And when we talk about lifestyle change, we talk about diet, how we eat, what we eat, and how we prepare it. exercising, and what we put into our body in terms of fluids. We should drink water regularly and stay away from sugared beverages such as sodas and high sugared juices. Water is the best thing that you can ever drink. And there again, biofeedback also helps with us being able to manage the symptomatology of benign prostatic hypertrophy. Next slide, please. Now we'll talk a little bit about the complications of drug therapy, because we always talk about what the drugs do to help us, but we don't talk about what the drugs do to hinder the therapeutic model. And some of these alpha blockers can cause dizziness. Sometimes they cause runny nose. They can cause retrograde ejaculation. By that I mean, when we ejaculate, it goes back into the urinary bladder because they relax the smooth muscles in the urinary tract so much that the ejaculate goes in the direction of least resistance. Impotence is also a problem seen with some of the medications, as we talked about 5-alpha reductase inhibitors, and decreased libido again from the 5-alpha reductase inhibitors. Constipation can be seen with some of these medications that we use to relax the urinary bladder, and again, blood vision and dry mouth. Next slide, please. Now, invasive therapy of benign prostatic hypertrophy include the use of some heat modality. And there are a number of them. Transurethral resection of the prostate, or TURP, is the tried and true. It has the longest efficacy. We have used it the longest in urology. However, there are others that have come about that may be a little less invasive, but yet are not as effective. Laser enucleation of the prostate is another form of therapy, just using laser beam to vaporize the tissue in the prostate. Rasium is new, and it uses heated steam to desiccate prostate tissue. The UroLift uses suture material to tag the prostate tissue away from the midline, and in so doing, open up the channel in order for you to urinate a little bit better. The jury is still out on UroLift because it only lasts perhaps for 5 years. I've seen it much less. And so we'll see how long it lasts as a treatment modality. Transurethral needle ablation of the prostate uses radiofrequency, and transurethral microwave therapy, or TUMT, uses microwave energy to desiccate prostate tissue. And last but not least, prostate arterial embolization uses embolization or obstruction of the arteries feeding the prostate in order to decrease blood flow and hence cell death. Next slide, please. Okay, we're going to move on and talk a bit about prostate cancer. Prostate cancer is essentially the abnormal growth and proliferation of prostate cells. It is the second most common cancer among men, second only to skin cancer, and it's the third leading cause of death in the Bahamas. This is recent World Health Organization data, and it's the fifth leading cause of death in men worldwide. Next slide. Data from 2020 showed approximately 1.4 million new cases diagnosed worldwide and 375,000 deaths as a result of prostate cancer. The Bahamas is in the top 10 list of prostate cancer mortality rate worldwide. And the countries that beat it out include Zimbabwe, which is number 1. Then following Barbados, Trinidad and Tobago, Jamaica, and perhaps 1 or 2 European countries, but we are in the top 10 list of the prostate cancer mortality rate. 1 in 9 men will develop the disease in his lifetime, and the disease tends to be more aggressive in men of African ancestry. Next slide, please. So we diagnose prostate cancer by a history and physical exam. As we stated earlier, we want to check your blood pressure, do a complete physical examination, of which again, the digital rectal exam is important. And we get lab work to include a urinalysis, PSA, comprehensive metabolic panel, and a CBC, as we discussed earlier. The newer trends in terms of diagnosing prostate cancer include magnetic resonance imaging of the prostate. We found that the MRI helps in delineating lesions in the prostate that perhaps we may not feel on a digital rectal examination. And we often do this in patients who would prefer to do something less invasive prior to proceeding with prostate biopsy and ultrasound of the prostate. Continue, next slide. So there are multiple ways of treating prostate cancer, and not all prostate cancer requires invasive therapy. Active surveillance has now become a part of the American Urologic Association guidelines for prostate cancer treatment, and these guidelines were revisited and renewed in 2018. Active surveillance involves following the patient, and active surveillance is used in patients who have low-stage, low-volume disease. So once we biopsy your prostate and find out that you have prostate cancer, if your disease is low stage and low volume, we tend to follow with active surveillance. And by that, we mean that we see you every 6 months, obtain a PSA, and depending on your decision with the patient, perhaps a prostate biopsy if your PSA starts to go up. More often, we are using MRI to evaluate the patient if the PSA starts to go up under active surveillance. But you are actively seen by a physician, examined every 6 months, and we ensure that your disease is not progressing. Surgery is also used in low stage, low volume disease. And by surgery, I mean surgical removal of the prostate. And we can either do that by open surgery or the latest and the greatest robotic prostatectomy. A lot more men are choosing active surveillance with low stage, low volume disease, and the outcome is improving as we go, but still we have to do a lot of research and development in order to see where active surveillance is going to take us. Surgery is not without its complications, and therefore we also look at radiation therapy, which do has its complications, but are different than what we see in surgery. So radiation would include either cyberknife, intensely modulated radiation therapy, or what we call brachytherapy, or radiation seed implantation of the prostate. When the prostate cancer progresses to metastatic disease or locally advanced disease, we incorporate medical therapy. And these medications act to decrease or deplete your testosterone in the body, because testosterone actively stimulates prostate cells, as I said earlier, both benign and malignant. And as a result, we have to discontinue that stimulation by giving you medication that would deplete your testosterone. Of course, there are side effects to that, but the outcome for the patient as a whole in their treatment for prostate cancer outweigh the risks of the side effects of these medications. Next slide, please. So as we said earlier, some of the complications of prostate cancer treatment include impotence, or the inability to obtain an erection, because the nerves that are responsible for erection literally sit on the outside of the prostate. They course along the outside of the prostate. If the prostate is removed, these nerves are either transected, or sometimes the blood vessels feeding them are damaged and therefore cause some nerve cell death. Incontinence is also a major problem with surgery, and we tend to see that more often than not. With radiation can damage the nerves that course along the prostate. However, incontinence is not seen with radiation. The other downside of treatment is residual or recurrent disease. Particularly in surgery, if there's residual disease, then additional treatment has to be carried out, and this can further result in complications of incontinence, impotence, and a severely reduced quality of life. These would be called post-treatment urinary tract issues, which include chronic pain, in some cases, fistula between the urinary tract and the gastrointestinal tract. Just the overall well-being of the patient's psyche can be affected negatively. And so all of these things have to be taken into consideration when we counsel patients about treatment and post-treatment complications and urinary tract issues. Next slide, please. Next slide. So I want to move on and talk some more about preventative health measures, because we tend to focus more. I split it up into reactive health measures and preventative health measures. We most of the time are responding to disease in a reactionary way as opposed to a preventative way. And the biggest issue is lifestyle. Metabolic syndrome affects all of this, and it is directly related to our lifestyle. If we have a sedentary lifestyle, how we prepare our foods and the type of foods we eat. In addition, sleep deprivation is a serious problem in our lifestyle. And we need to, I know we don't think about that too much, but sleep deprivation affects the way our immune systems respond. And the immune system is directly involved in fighting disease and inflammation in the body. We should visit our doctors annually, because some diseases or situations are silent. And when they do present or speak out, you may be at a point where even reactive medication or reactive medical therapy may not prove to improve your lifestyle or your sense of well-being. I like to include meditation and mindfulness, because we all need to slow down and stop and do some introspection and retrospection in order to find out where we are going. Meditation helps to slow the body down. It improves your immune system and your immune system response. And again, the immune system is intimately involved in fighting disease processes, particularly malignancies. And spirituality speaks for itself. We should always take some time out to commune with the Creator. I know not all of us worship in the same way, but I am sure most people have some form of spirituality to which they prescribe or subscribe. And I think that whatever that is, or whatever mode that is, we should seek it out, because it provides a sense of calmness, a sense of oneness, and a sense of well-being that can only help in the process of good health measures in the process of a positive mental attitude, and ultimately a positive sense of well-being. Next slide, please. I thought I would include this little take-home message, and I call it change. The only constant in life is change, and it is inevitable. We don't change until the pain of staying the same is greater than the pain to change. So I'll leave that with you and open up the floor for questions at this time.
Excellent, and thank you so much, Dr. Williams, for your presentation this afternoon. Extremely informative. And I've got a couple of questions based on your presentation. And if you can, for those of us that are, or those in the audience that are not in the medical field, who may not understand terms like BPH and chronic versus acute, can you define those for us, please?
Okay. So BPH is benign prostatic hypertrophy. In other words, benign growth of the prostate. That happens inevitably in all men because of our production of testosterone. The testicles and the adrenal glands do not stop producing testosterone in our lifetime. And testosterone stimulates the growth of the cells in the prostate. And that ultimately causes the problems that we talk about with frequent urination, slow urination, urinating a lot at night, or what we call nocturia. So yes, benign prostatic hypertrophy is the benign growth. Prostate cancer is the malignant growth of those cells, and that is the malignant growth unchecked. I hope I made some sense and answered the question.
Okay, so I'm going to ask you another follow-up question. Define for us malignant versus benign.
Say again?
Can you define for us malignant versus benign?
Okay, yes, definitely. Benign means that it grows, but there's no cancer.
Okay.
Malignant means it grows, but there's cancer. In cancer, the cells grow unchecked. In other words, see, the body is designed such that when the cells in our bodies grow, when they touch each other, that growth stops. But in cancer, the genetics of cancer does not allow the cessation of the dividing of the cells, so the cells just continue to grow and grow. And that's why over time, the cancer nodules become larger and larger in the body. Now, benign growth does not quite grow that way. And the cells are not cancerous.
Okay, great. Excellent. Thank you for those definitions. I think those are important for the laypersons that are on the call.
Oh, I appreciate that. Thanks.
Yeah. So the other thing I need you to define for us is incontinence versus impotence. Can you define those two terms for us, please?
Yes. Impotence is the inability to get an erection. It's the same thing as erectile dysfunction, the inability to get an erection. Okay, whether or not the erection is adequate for penetration, it is the inability to get one. Okay, incontinence is the involuntary loss of urine. In other words, you leak urine on yourself and you can't control it.
Excellent. So there is the elephant in the room is this whole thing around digital rectal examination. Is that the only approach to identifying these diseases or examining the prostate? Is there an alternative to digital rectal examination?
I wouldn't say there's an alternative. The American Urologic Association and the Comprehensive Cancer Care Network addressed this issue in 2018 because it is a controversial issue. as to whether or not we have to do a digital rectal examination. And the reason why we do it is because the prostate can be easily accessed and palpated through the rectum because it sits right on the anterior rectal wall. And we can feel hard nodules in it. It is a part of the constellation of things that we do in order to determine whether or not you are at risk for prostate cancer. And so you do a digital rectal examination, you can do ultrasound. MRI has helped to improve our ability to bring things together and to determine whether or not we should proceed with something as invasive as a prostate biopsy. Because if we suspect that you may be at risk, the next thing will be the prostate biopsy. The digital rectal exam helps to confirm or deny that decision in some ways. Now, the guidelines are that if you have a family history of prostate cancer, most of us should, and particularly if you are of African ancestry, we should start the process at age 40. Some of us should be examined annually, particularly if you have an aggressive form of prostate cancer. And by that, I mean where you have multiple men in your family who had prostate cancer and may have gotten it at an early age. So start at 40 every year. Those who have less of a risk, you can do it every other year until you reach the age of 50, and then annually thereafter. If you have no family risk whatsoever, some of us allow you to continue up to age 45 before we start doing the exam. And we do it every other year until you're at the age of 50. At 50, we go annually. Now, when do we stop? Well, the Comprehensive Cancer Care Network says when men reach the age of 75, if they don't have a 10-year life expectancy and their PSAs are low and they have a normal digital rectal exam, perhaps we can stop. The American Urologic Association increased that number to 80. And so the whole idea, there should be a discussion between the patient and the physician and the decision made in that way. But do we get rid of the digital rectal exam? No, we can't throw out the baby with the bathwater. And so we have to have some means. I mean, we examine the abdomen to feel for masses if someone comes in with abdominal pain. So if you're coming in with some problems with the prostate, we have to examine the prostate. And the only way to get to it in order to feel it is transrectally.
Thank you, Dr. Williams. Now, you know that's a challenge for our men, right?
I do know. But, you know, it's an ounce of prevention for a pound of cure.
Understood. So we've got a couple of questions in the chat. The first one is, and I'm not sure you're able to answer this, but if you can speak to it and as best you could, we'd appreciate that. So someone wants to know specifically what type of treatment is available in the country for Bahamians with prostate cancer, and then how can they reach out to you and see you as a patient?
Well, that's a good question. Currently, I know there are physicians doing removal of the prostate and perhaps external beam radiation. We don't have brachytherapy or transperineal radiation seed implantation. And of course, we don't have the ability to do robotic prostatectomy. However, the ability to do an open prostatectomy is there, and I know it's being done. Now, off the record, there has been some inquiry into incorporating brachytherapy into the regimen in some way, and that will require some additional evaluation and research in order to bring it to fruition.
Okay, great. Thank you so much for answering those questions. So I have another
Now, if
question.
they ask how can be, well, to get to me, currently, I've treated some Bahamians here. To get to me currently, I would have to do treatment here, but I'm in the process of trying to establish some means of being quasi Bahamas and Maryland in order to be able to provide some additional means of treatment.
Okay, great. Perhaps we can share, or I can have individuals reach out to me if they want to contact you directly. And for those of you on the chat that may be interested, my phone number is 824-7720, or you can reach me at the National Health Insurance Authority. So my direct number is 824-7720, and I'd be happy to put you in touch with Dr. Williams. And it's Dr. Sandra McDonald. So Dr. Williams, the next question that we have revolves around, you talked about risk factors as related to all these conditions related to the prostate. So talk to us a little bit more about the prevalence of alcoholism in our country, smoking, especially weed among our young people, and talk to us about the impact on such behaviors related to all these conditions you describe, and how can we be proactive in terms of minimizing the level of impact for our population, given our culture.
Mm-hmm. It's not just alcohol and smoking, it's also in the diet. I mean, how we prepare what we eat. But let's talk about alcohol and smoking. Cancer is essentially chronic inflammation. Basically, that's the basic concept of what cancer is. Smoking and all of those additives in tobacco smoke, as well as alcohol, stimulate a lot of inflammation in the body. And they don't just increase the risk of prostate cancer, they increase the risk of all other cancers in the body. So when we cut down, and alcohol, let's face it, is high in sugar. Sugar is the number one stimulant of inflammation in the body. So in order to mitigate our risks for cancer, period, by cutting back on all of these products, tobacco products and alcohol, we would decrease the likelihood of us developing cancer. Eating, I mean, frying, or what we call high temperature cooked food, increases the carcinogenic effect of the foods. So we're better off broiling, baking, and perhaps even grilling, but not grilling to whether the meat or whatever is charred, because we're trying to avoid the carcinogens that result from high temperature cooking. So yes, alcohol and tobacco are a serious problem. And of course, I mean, we are a society where entertainment is centered around food and beverage. And so whether even it doesn't have to be alcoholic beverage. I mean, if we're drinking high sugared beverages, it's the same thing. So yes, these things can increase our risk for cancers of any kind.
Thank you. So our young people will tell you that smoking weed is good for them, right? Can you address that issue for us, and the impact on?
It's still you're still imbibing carcinogens, in the long run. I mean, it's going to affect affect you from a pulmonary standpoint, particularly chronic use in large amounts, yes, because of the way it's entering your body. You can cause chronic bronchitis, the initiation of inflammation in the lung, and just like tobacco smoke can cause you to get lung cancer, so can smoke of any other kind.
Excellent. Okay, thank you very much. Any other questions, Chandra? I'm going to open it up to you if you have any questions for Dr. Williams before we wrap up.
I just received one question that came in from a private message. An individual wanted to know what causes low testosterone levels in men and how is that treated? How can it be treated?
That's a good question. Testosterone is produced in the testicles and the adrenal gland. If we have problems with the testicle, that in and of itself can cause decreased testosterone. If you have testicular injury, for example, there's an entity called testicular torsion that occurs a lot in young men, adolescent men, as the testicle starts to grow, and that causes ischemia or decreased blood flow to the testicle and affects the cells in the testicle that produce testosterone. They're called the Leydig cells in the testicle. The other thing, and a big thing, this is why I brought up this metabolic syndrome, obesity. Obesity is a serious problem for testosterone level. And why? Fat cells have an enzyme in them called aromatase. And aromatase converts testosterone to estrogen. And estrogen is not good for men. Only good estrogen is the only good of estrogen in men is when you have prostate cancer. And we used to use estrogen to treat that back in the day, but that can cause some problems. High estrogen can cause coronary artery disease in men. So if you are obese, and this is, if you remembered, I said we have an adage, look down, if you cannot look down and see your pee-pee, your problem is your belly. Testosterone is converted to estrogen, and that's why obese men have breasts, because it stimulates the growth of the fat tissue or the mammary tissue. And this in turn affects our testosterone levels, lower them, and can decrease our sense of well-being, can decrease our sex drive, decrease our body muscle mass, and also cause osteoporosis or thinning of the bones. So yes, the primary cause of low testosterone is essentially obesity. Now, how do we treat it? There are multiple ways. Nowadays, we have some newer modalities where there's a nasal spray. There are more safe pills that we can use, because heretofore the pills that were used for testosterone treatment were causing some ill effects to the liver. And so up to this point, we were using more injection of testosterone or patches that contain testosterone and slow released it into the blood. So you would put the patch on your skin and keep it on for so long to release testosterone through the skin into the blood. We also have ointments, or what we call topicals that come in a lotion type form that we rub on the body, and they absorb through the skin, and that increases our testosterone level. There are also depots, so you can put, we can inject a depot or give you an injection just beneath the skin, and that testosterone is released over time and to keep your testosterone levels up. One of the better things when men are obese, we recommend that they lose weight and exercise, because I've seen the testosterone level increase to normal levels in men who have undergone gastric bypass surgery and lose an excessive amount of weight, or men who just take it upon themselves to exercise and get the weight off. Once you get rid of those fat cells, the testosterone levels come up. And I've seen some drastic change in testosterone levels in patients who took it upon themselves to lose weight.
So it's all definitely about a lifestyle and behavioral change, is what I'm hearing from you, Dr. Williams. It plays a
Absolutely.
big factor in everything. That's pretty much our healing. Lifestyle, behavioral changes.
Metabolic syndrome matters.
Thank you for that.
Yes.
And so I haven't received any other questions, Dr. McDonald.
Okay, so we have one last question, Dr. Williams. There's someone on the session wants to know about testicular torsion. Can you discuss that a little bit?
Yes, absolutely. Testicular torsion is when the testicle twists on its vascular pedicle or the blood vessels that bring blood in and take blood out of the testicle. So it will twist on it and the blood flow will just be stopped. And so the testicle, if it is not addressed within 6 hours of twisting, the testicle will die. It's seen primarily in adolescent boys from the ages of, you can see it in infants, but primarily from the ages of perhaps 11 to mid-20s. This is the period when the testicle begins to grow. This is when we get our testosterone surge. And sometimes the vascular pedicle is not wide enough to support the testicle as they grow and hang in the scrotal sac. There is a structure that pulls the testicle into that sac because your testicles start in the abdomen. When you were in utero or developing in the womb, your testicles are primarily in the abdomen next to your kidneys. And as the body grows, they migrate into the scrotal sac. And there is a structure on the lower part of the testicle that help to pull them into the scrotal sac and anchor them there. It's called the gubernaculum testis. In some boys, the gubernaculum testis is absent, and so the testis can swing in the scrotum. And as a result, a child can turn over in the bed, or if they play sports, running on the soccer pitch or running around the bases, that testicle turns, and when it twists, the blood flow is compromised. It's associated with severe pain, and the testicle pulls up into the groin, and it has a transverse lie. Usually the testis is hanging up and down, but in this case, it hangs from left to right, either side. So we call that a transverse lie. So if you have male children and they present to you with any kind of pain in the testicle, suspect it, especially in that age group.
Excellent. Thank you, Dr. Williams, for
and that has to be fixed by surgery, by the way.
Excellent. Thank you for answering those questions for us. This has been an extremely enlightening and informative session, and we are grateful for the information. We hopefully can have you back at some point in time on another one of these sessions as we continue to try to create awareness among our patient population to enhance the health and the well-being of all Bahamians. For those of you that are on the presentation, I want to make you aware that these sessions are being recorded and they will be available on NHI YouTube channel. So I encourage you, if you have friends and colleagues and family members that may have missed the session this afternoon, you can go to our YouTube channel and share it with them. The other things we want to make you aware of is these sessions are monthly, and every month there are different topics we're addressing. And so our goal is to bring information to the Bahamian public, keep them aware of all the issues and the concerns that we have to address in country. And whenever there is a topic on a monthly basis, we try to address those issues. Want to also share with you that every month we have a power hour, where this month it's an exercise session every third Thursday of the month, and it's a complimentary power hour where it's conducted by a certified fitness instructor And it's about a 1-hour session where we just try to engage the public to come out and exercise. This month, over the summer months, it's being hosted at Holy Cross Auditorium in region, I think that's Highbury Park, yeah. And you're welcome to join us. We also send out a newsletters that you can connect with us on Facebook or any of our social media platform, Twitter, whatever. We're out there, and you can also check out our website. So our goal is to make sure we keep you informed. If there are topics or questions that you have, feel free to reach out to us. Our phone number is 242-396-8500. And our goal, like I indicated earlier, is to keep you informed, have you share these very informational, informative topics with your colleagues and friends, so that together, as we try to transform healthcare in our country, we're keeping our public and our beneficiaries informed, and we're engaging them, and together we're growing as a nation. We understand that the wealth of a nation is the health of our nation, and we want to impact lifestyles and behavior modification, making sure individuals understand the importance of lifestyle changes, and making sure that they understand the impact of the things that impact healthcare, social determinants of health, and each of us taking individual responsibility for how we take care of ourselves, and then sharing that information with others and challenging others to eat better, exercise, and of course, like Dr. Williams indicate, take some time for yourself, meditate, and take a walk on the beach, and just be introspective, and minimize stress. And so we'll continue to bring these sessions to you on a monthly basis. Encourage you to please share with your colleagues, friends, and family members, so that together we can continue to get better as a nation. So thank you all for the gift of your time this afternoon and coming and joining this session. We look forward to these sessions in the future, and please spread the word. So thanks again. Have a wonderful afternoon. And if you have questions or concerns, make sure you reach out to us. Diego, coffee drinking is not an option. I think, like Dr. Williams said, all these sugary drinks is a problem. So thanks everyone for a great time this afternoon. Thank you for joining us. Thank you for sharing, and thank you for your questions, Dr. Williams. We're indebted to you, and thank you for a very informative session this afternoon. Good afternoon, everyone.
The feelings are mutual.
Okay. All right. Thank you. Good afternoon, everyone, and have a great evening. Take care.
All right.